have a theme.
Yes, thank you. Okay. Excellent. Good morning, everybody. It's a pleasure to be here today at the Best of Lung 2023. So today I will be discussing targeted therapies in lung cancer. These are my disclosures. So in the US, there are an estimated 230,000 new cases of lung cancer and over 150,000 deaths from lung cancer each year. And lung cancer is by far and away the leading cause of cancer-related deaths in the US and worldwide. Here, it accounts for a staggering 1 in 4 of all cancer-related deaths in the US, with more people dying of lung cancer each year than colon, breast, and prostate cancers combined. About 85% of lung cancers can be classified histologically, as we heard earlier, as non-small cell lung cancer, and that's mainly what I'll be talking about today. And most of these patients, unfortunately, do present with advanced stages of disease where curative approaches are not usually possible. And so for many years, before I started practicing certainly, but the standard of care for advanced lung cancer was chemotherapy doublet regimens, so mainly platinum doublet regimens. And so these chemotherapy platinum doublet regimens really all performed relatively similarly in terms of overall survival and time to progression, with really poor outcomes on the order of months for our stage 4 patients. Now, in 2006, the field shifted a tiny bit when a study demonstrated that the addition of Avastin or bevacizumab to chemotherapy had a marginal but significant survival benefit. So platinum doublet therapy, chemotherapy plus or minus Avastin was really the standard of care for advanced non-small cell lung cancer treatment until about the early 2000s. And that's when things really started to change. So excitingly, over the last 10-15 years, we've seen tremendous advances in the treatment of non-small cell lung cancer with rapid pace of regulatory approvals of all of these novel agents. So this started with the approval of crizotinib for non-small cell lung cancer in 2011 for ALK-positive disease, erlotinib or Tarceva for EGFR mutant disease in 2013, and a series of other immunotherapy agents shown in red and targeted therapy agents shown in blue, which we'll review in more detail today. So in addition to our traditional cytotoxic chemotherapies, we have witnessed the emergence of 2 other treatment paradigms that we're all familiar with: targeted therapy and immunotherapy. And when we talk about targeted therapy, typically what we're referring to is a small molecule inhibitor of typically a kinase that cancer cells really depend on to drive their cell proliferation. And broadly speaking, when we talk about immunotherapy, which it sounds like we'll be talking a lot more about tomorrow, we're referring to anti-CTLA-4 or anti-PD-1 or PD-L1 inhibition. And these are agents that serve to disinhibit the immune system through activation of T cells. And so once upon a time, as we heard about from Dr. McKell, non-small cell lung cancer was sort of thought about as non-small cell or small cell, and then we moved towards histologies. And we, of course, do still take histologies into account for treatment, but we now have to routinely sequence lung tumor specimens with next-generation sequencing technologies to identify the presence of potentially an actionable oncogenic driver alteration. And the reason that NGS testing is so critical is because now there are several FDA-approved targeted therapy agents that match their respective oncogene. So this is true for oncogenic driver alterations including EGFR, BRAF V600E, MET exon 14 skipping alterations, KRAS G12C, which we already heard about, as well as chromosomal translocation events or fusion events involving genes ALK, ROS1, RET, and TRK. So it is a Category 1 NCCN recommendation but for all treating physicians to perform broad molecular profiling at initial diagnosis in patients with advanced non-small cell lung cancer, namely adenocarcinoma. And as someone pointed out before, the NCCN guidelines say consider molecular testing for squamous cell. And so this goes beyond, again, just testing for EGFR, ALK, and ROS1, which is what these guidelines said a couple years ago, and now it has expanded to testing for BRAF, NTRK, MET exon 14 skipping, RET rearrangements, HER2, and then of course looking at PD-L1 status. And of course the reason we want to test upfront at the time of diagnosis is because several of these biomarker-directed therapies are approved and recommended as first-line treatments, shown here by the blue arrows, with a few others currently approved in the second line or in subsequent therapies. So generally speaking, our algorithm for treating advanced non-squamous, non-small cell lung cancer is as follows. A patient receives a biopsy of his or her tumor. They undergo molecular genotyping in addition to evaluation of PD-L1 status. And if there is an actionable oncogenic driver alteration for which a targeted therapy is approved in the first line, they will go on to receive that targeted therapy agent. So this is a case of a patient that I saw a couple years ago, a 55-year-old woman, never smoker, originally from China. She presented to my clinic with 3 weeks of dyspnea exertion, dry cough, and fatigue. You can see her chest X-ray and her chest CT shows diffuse bilateral opacities. She underwent a biopsy which showed EGFR mutant non-small cell lung cancer with an L858R alteration. She was started on a third-generation EGFR inhibitor called osimertinib, and within 6 weeks, she had significant symptomatic improvement and excellent radiographic response to therapy. So interestingly, Dr. McKell talked about this, stole a little bit of my thunder earlier on, but going back 20 years, EGFR inhibitors, for example, gefitinib, was first tested in the early 2000s in an unselected patient population, and trials were overall very underwhelming. But some keen investigators, as we heard about, did note that patients who had substantial responses to therapy indeed harbored a mutation in the EGFR gene. And so patients, for example, who had received gefitinib and harbored an EGFR alteration, either an exon 19 deletion or L858R, benefited from this type of targeted therapy. Then the question became whether patients with an EGFR mutant lung cancer should receive first-line targeted therapy or first-line chemotherapy, which, as I mentioned, had been the standard for many, many years. So this is a list of phase 3 clinical trials of EGFR tyrosine kinase inhibitors, or TKIs, in EGFR mutant lung cancer, all of which showed superiority of EGFR inhibitors compared to chemotherapy in the first-line setting. And these studies really represent a paradigm shift in the field in which targeted therapy agents sort of supplanted chemotherapy as the preferred first-line treatment. And then over the last 15 years, various companies have developed successive iterations and generations of tyrosine kinase inhibitors in the EGFR space with the goal of improving selectivity against EGFR mutant protein and not the wild-type protein in the hope of alleviating side effects and toxicities we were seeing. So we think about these first-generation EGFR inhibitors that are sort of more historical at this point, but I do have a couple patients who are still on these EGFR inhibitors left over from a decade ago. So these are erlotinib, gefitinib. Think about second-generation inhibitors, afatinib and dacomitinib. But as we heard just before from Dr. Kazmi, that now the standard of care for EGFR mutant lung cancer in the first line is osimertinib, which is a third-generation EGFR TKI. It's irreversible, and it has preferential activity against sensitizing EGFR mutations in addition to the T790M resistance mutation. So osimertinib was initially, as we heard before, approved in T790M EGFR resistant mutation context in the setting of patients who had already received a first-generation EGFR TKI. And you can see here this impressive waterfall plot from different dose levels used, which showed significant responses in EGFR mutant patients who harbored a T790M resistance alteration. So after it had showed promise initially in the second-line setting, this is what we do. We move things up to first line and test them in that setting. And this is data from the seminal phase 3 FLORA study published in 2018, which examined osimertinib in untreated EGFR mutant advanced non-small cell lung cancer against a first-generation TKI, gefitinib or erlotinib, and you can see very impressive hazard ratio of 0.46 for progression-free survival, with patients doing significantly better on osimertinib in orange, median PFS of about 19 months versus 10 months. So based off of this data, osimertinib, like I said, is now our standard of care for first-line therapy of EGFR mutant non-small cell lung cancer. So TKIs in general for oncogenic drivers, as I've just shown you for EGFR mutant disease, are highly effective, but this was already alluded to earlier, that acquired resistance to targeted therapy essentially always occurs. We don't think of these TKIs as curing people largely. We know that patients are likely almost always going to relapse. And so resistance to targeted therapy can take many forms. We can see alterations in the driver itself, for example, in EGFR itself, that renders TKIs ineffective. We can see bypass pathway alterations that are upregulated to become target independent. And then we can see other mechanisms such as lineage transformation as well. And so, of course, a very active area of research right now in EGFR mutant lung cancer and other oncogene-driven lung cancers is to try to uncover the landscape of resistance mechanisms that occurs in patients who progress now on first-line osimertinib. And so a subset of patients, we can see, like I said, on-target alterations or mutations in the EGFR gene itself, shown in blue. We can see off-target alterations, shown in green, things like BRAF, RET, and most commonly MET amplification, which I'm going to talk a little bit more about. And some patients do develop histologic transformation to small cell or other histologic subtypes. And so there are various clinical trials in place that are enrolling patients who have specific identifiable resistance mechanisms post-osimertinib to test whether combination therapy in this setting is effective. And so as I showed previously, one of the most common, what we say, off-target resistance alterations to EGFR inhibition is something called MET amplification, so genomic amplification in the receptor tyrosine kinase called c-MET or MET. And so preclinical studies had shown that co-inhibition of EGFR and MET is potentially a viable therapeutic strategy. And early phase clinical trials like the TATAN trial that I'm showing here were carried out to test this rational combination to overcome resistance in EGFR mutant disease that was driven by MET amplification. And then the strategy used both osimertinib and a MET inhibitor, savolitinib. And so one of the key messages here actually is, of course, in addition to testing at the time of diagnosis, it's also critical to test these patients at the time they develop resistance. So for example, we routinely perform testing to look for MET amplification, mostly by FISH, to evaluate for escape pathways so we can consider clinical trial enrollment, particularly in MET-driven resistance in EGFR mutant lung cancer. And so everything I've talked about so far has been in the context of advanced non-small cell lung cancer, but as we've been hearing about, the paradigm in oncology is that drugs are typically tested in later phases and then slowly move to earlier phases. And so we just heard a wonderful summary from Dr. Kazmi on this. The ADAURA phase 3 study was this seminal trial which enrolled patients with EGFR mutant early stage lung cancer, stage 1B to 3A, who underwent complete surgical resection with negative margins. They were treated plus or minus adjuvant chemotherapy, and then they were randomized to receive osimertinib for 3 years versus placebo. And like Dr. Kazmi pointed out, based on this striking DFS, disease-free survival data in these patients, osimertinib is now our first targeted therapy approved as adjuvant therapy in surgically resected EGFR mutant lung cancer. And so more recently, again, as we heard, we saw that the DFS benefit very importantly translated into an overall survival benefit. So we know that we are curing statistically more patients with this treatment approach. And this is a hazard ratio of about 0.49 for stage 2 to 3A disease. Now switching gears here a little bit to different types of oncogene-driven lung cancers. So ALK rearranged disease represents about 5 to 7% of advanced non-small cell lung cancers. These typically occur in patients who were younger, age, never a light smoker, adenocarcinoma histology, and amazingly enough, we have 5 ALK TKIs that have been FDA approved, starting with crizotinib that was approved back in 2011. So ALK translocations, or these chromosomal rearrangement events in ALK with another non-native N-terminal binding partner, they're very potent oncogenic drivers in non-small cell lung cancer. Thus, ALK inhibition with the TKI crizotinib here, for example, showed striking objective responses in patients with ALK rearranged disease. And so similar to EGFR mutant lung cancer, we've seen iterative development of different generations of ALK tyrosine kinase inhibitors from the first approval with the first generation drug crizotinib back in 2011. I still have some patients actually left over on crizotinib from that time who started originally on trial. And then second generation inhibitors have been developed, ceritinib, alectinib, brigatinib. And then most recently, we have our third generation inhibitor in this space called lorlatinib. And with each of these generations, we see enhanced potency against the target itself, ALK. We see improvement in CNS activity, which is very important because many of these patients do have CNS disease. And then we see a broader activity against secondary ALK resistance alterations. And so here I'm just showing the PFS data, the progression-free survival data from the ALEX trial on the left, which tested the second generation ALK inhibitor alectinib versus crizotinib. And on the right is the ALTA-1L trial comparing the second-generation ALK inhibitor brigatinib to crizotinib. And both of these second-generation inhibitors, as you can see, showed superior efficacy in progression-free survival compared to our first-generation inhibitor crizotinib. So then our third-generation ALK TKI was developed, again, with increasing potency against the target, increasing selectivity, and increasing CNS penetrance. The drug is called lorlatinib. And this was tested, again, versus crizotinib in the first-line setting in the CROWN trial, published in the New England Journal in 2020, with a very striking hazard ratio of 0.28. And again, look at that PFS plot. That difference in outcomes of patients who receive lorlatinib versus crizotinib is truly striking, with the median PFS of lorlatinib not even being reached. So similarly to EGFR mutant lung cancer, we can see a variety of resistance mechanisms to ALK TKI. So we published this review earlier this year in Nature Cancer, which summarizes these mechanisms. So of course we can see on-target ALK resistance, in which there are single or compound mutations in the ALK gene itself that render drugs ineffective. That happens in about 20 to 30% of patients. On the right, we can see lineage transformation, which is devastating but fortunately rare. And the most common thing that we see here is, again, bypass pathway activation to subvert dependency on ALK. And so there are clinical trials available also in this space, in the ALK space, testing rational combinations of ALK inhibition plus bypass pathway inhibition, for example, MET, SHP2, and MAP kinase inhibition. And also similar to EGFR, you can tell there's a theme here that in the ALK space, they take a lot of sort of hints from the EGFR space, but similar to EGFR mutant lung cancer, there's an interest in understanding whether moving some of these ALK tyrosine kinase inhibitors to earlier stage settings improves outcomes. So this is just a press release. We don't have the data for this yet, but this is from the ALINA trial, which tested alectinib as adjuvant therapy after surgically resected disease. A little bit different from the ADAURA trial in that it did not have adjuvant chemotherapy as part of this, but it did, according to the press release, meet its primary endpoint, so it would be very interesting to see what the data here shows. So ROS1 fusions is another oncogenic driver in lung cancer, representing about 1% to 2% of non-small cell lung cancers. A variety of ROS1 TKIs have been developed and tested in patients with ROS1 translocated disease. Some of these inhibitors might look familiar to you because we've talked about them so far. So crizotinib and lorlatinib work both on ALK and ROS1. But it is actually very important to know, we've seen this happen many times actually, that not all ALK TKIs work on ROS and not all ROS1 drugs work on ALK. So there's not a one-to-one relationship here. So it's really important to sort of know the data and what the appropriate TKIs are for each setting. So crizotinib and entrectinib are FDA-approved agents in the first-line setting. And it's actually a very active space here. There are a lot more next-generation ROS1 inhibitors being developed in clinical trials. RET fusions, as we heard someone mention earlier today, represent another small subset of non-small cell lung cancer on the order of 1% to 2%. The Libretto trial and the ARROW study tested RET TKIs, selpercatinib and pralsetinib, in RET-positive non-small cell lung cancer, and we can see really impressive overall response rates in the order of 60 to 80% in the treatment-naive setting. So these are approved standard of care agents in the first line. A major consideration here with a lot of these TKIs that we've talked about so far is CNS penetrance and CNS efficacy. As I mentioned, a large percentage of our targeted therapy, of our oncogene-driven lung cancer patient populations do present with CNS metastases at the time of diagnosis or develop them during their treatment course. And so there are certainly varying degrees of CNS activity for all of these drugs I've talked about so far. So here is just an example of some waterfall plots showing CNS activity for these RET inhibitors, selpercatinib and pralsetinib. So really important to understand the data here. NTRK fusions, so we've talked about ALK fusions, ROS1 fusions, RET fusions, and here we're talking about TRK fusions in non-small cell lung cancer. This represents a small piece of the pie chart, about less than 1%, but important to test for as we do have excellent targeted therapy options. Two agents, larotrectinib and entrectinib, are used in NTRK-positive non-small cell lung cancer, with larotrectinib being the newer agent, and you can see about a 73% objective response rate and median PFS of about 3 years. And for MET exon 14 skipping alterations, which actually represents a fair bit of the pie chart, we see this in about 3 to 4% of non-small cell lung cancer. This is an example of capmatinib, a CNS penetrant MET inhibitor, was tested in the Geometry Mono 1 phase 2 study and showed impressive efficacy in both treatment-naive and previously treated populations. And you can see a CNS response rate of about 54%. For BRAF V600E mutations in non-small cell lung cancer, we have the approval of combination TKIs, dabrafenib plus trametinib. It's approved on the basis of a phase 2 study in treatment-naive and both previously treated patient populations, again showing overall response rates on the order of 60% and progression-free survival on the order of 10 months. And then lastly, I won't spend too much time on this because we heard an excellent presentation from Dr. McKell, but there is a large chunk of that pie chart that's represented by KRAS, and in particular KRAS G12C in non-small cell lung cancer. And so we do have some data from KRAS G12C inhibitors that are currently approved in the second-line setting. This is data from the CodeBreak phase 2 study showing sotorasib with an objective response rate of about 30%. And then this is from the Crystal-1 study showing adagrasib, KRAS G12C inhibitor, with a response rate of about 45%. So overall, we've reviewed that next-generation sequencing testing is critical at the time of diagnosis to characterize the molecular landscape of lung cancers to identify actionable oncogenic driver alterations. So just to summarize briefly, novel targeted therapy agents are significantly impacting survival, as we heard about earlier, in advanced non-small cell lung cancer and the prognostic outlook for these patients. Targeted therapies have certainly transformed the diagnostic approach and our treatment approach in lung cancer. Genomic profiling with next-generation sequencing is really critical at the time of diagnosis to identify opportunities for these targeted therapies. And there are certainly other emerging drivers that I didn't have time to talk about today with targeted therapy options that are being tested in trials. And also, like I mentioned, these efforts, there are ongoing to move these agents from later phase trials into later stage cancers into earlier stage cancers to understand if we can cure more patients in that setting. So I'm happy to take any questions, and we'll also be talking more during the panel session as well. Thank you.
Thank you. Any questions?
So this was the question I was going to ask to Shaiman, but I'm going to ask it to you. In the early stage, she mentioned, should we be testing just for EGFR?
Gosh.
Or should we be doing NGS for all these things? And you mentioned how, okay, now there's ALK in early stage cancer.
Yeah.
So we got EGFR and ALK. And then, all these others, those are going to be tried in early stage too. So when are we going to start doing this comprehensive testing in early stage? And
Such an important question, Dr. Boyle. So the sort of simplest answer would be our only currently approved targeted therapy agent in the adjuvant setting right now is osimertinib, right? We saw a press release from the Alina trial, and obviously we want to see the data and TBD whether it will ultimately be approved in the context of ALK-positive disease. But the simplest answer would be because EGFR mutations are the only ones we can actually act on, the simple answer would be to test EGFR alterations at this time, at this moment. At academic institutions such as mine, we typically actually do send a broader panel, which is problematic because if we get information about an alteration, we don't have evidence or we don't have an FDA approval to act on it, it becomes a little bit tricky. So that's when things are sometimes done off-label, conversations with patients. If we know about clinical trials that are ongoing, then we certainly refer to a clinical trial if possible. But this will become a lot more complicated in the future as we're going to see more approvals for early stage targeted therapy. Yeah.
Thank you.
Yeah.
Thank you so much. I have a specific question about RET.
Mm-hmm.
I realized that even in the treatment-naive settings and the patients that were pre-treated, the response rates are very similar, and so there's really not as strong, compelling reason to do this RET-directed therapy first line versus second line. I don't know what your philosophy is. I tend to think treat the driver mutation first, but is that the correct pathway? Is that what you do with RET?
It is, yes. Selpercatinib and pralsetinib, yes, are technically FDA approved and recommended per NCCN guidelines as first line
Even
therapy.
though they have similar
Yes.
efficacy even in the second line setting?
Yes. Yes.
So you save the chemo for later.
I do. It's easier to tolerate, and patients, like we sort of talked about already, are more likely to be adherent and compliant with a pill form and are more enthusiastic about than chemotherapy, yes.
And I'm going to just piggyback one other question. I know that a lot of these targeted agents are approved in the second-line setting, and we tend to use chemo-IO first line. I know there's concern, of course, with IO interacting with TKIs.
Yes.
We know that with EGFR agents very well, and we tried to separate that out 3 to 6 months because of toxicity. Do we know enough with these other agents? Do we have to separate the IO 3 to 6 months? What do we do?
Yeah, it's an excellent question, and one I don't think we have a clear answer to. In the EGFR space, we do. In the ALK space, we do. In the other spaces, we don't. So, for example, I have a patient now who's on first-line capmatinib for MET exon 14 skipping alterations, and he's sort of looking like he's progressing. And we've started talking about next-line treatment strategies, which would typically, standard of care, be next-line chemotherapy plus immunotherapy. And I've sort of polled the people in my practice to get a sense of what people would do, and it's like mixed. Some people would offer immunotherapy, and some people have, say, we don't have a lot of data in this space, and there could be toxicities that we don't necessarily know about. So I think we do need more data in these other targeted therapy spaces, and we just don't have a lot of that now. But definitely a risks-benefit discussion with the patient. I think it also depends on sort of the smoking status of the patient too, because patients who have a history of smoking, for example, some MET patients do have a heavy smoking history, and so in that situation, their PD-L1 might be a little bit higher, and you might be a little bit more enthusiastic about trying IO, even with the understanding that there might be some unwanted adverse events. Yeah.
I was going to comment on the testing. I think testing early patients, we don't only test to figure out what adjuvant treatment to give, but to understand the disease and even guide the surveillance.
And
so,
prepare for if they come back.
Correct, and conceptually, yes, of course, but also guides the surveillance. We know that patients with EGFR, ALK-1 might actually recur in the brain more often than people with other mutations. And in these patients, you could consider brain imaging as part of the surveillance. Look at how many patients with brain metastases actually in the ADORA study. I was looking at the exon 20 insertion data from Australian group collected, and actually 40% of the early stage exon 20 insertion, 40% of the patients, their first site of recurrence was the brain. So when you start knowing the natural history of your disease, you tend to have a better feel of the multifocality of disease, types of recurrence, etc. So I think we should be testing NGS.
Yeah, I agree. I totally agree. As an academic, right, we want sort of more information. We want to understand the disease biology of some of these oncogene-driven lung cancers, although I do have to say it's hard. I have been in a situation a couple times where we've sent a large panel of molecular testing and something not actionable in the early stage setting comes up, and you have to have a conversation with the patient. Well, it's approved in the metastatic setting, but not in the early stage setting. And then they say, well, would I benefit? In 10 years from now, are there going to be trials that have shown benefit in my situation? And I don't know. So sometimes those conversations are hard to have.
Yeah, I think, the problem is reimbursement in the broader setting. If you're doing an academic research or like a sponsored panel, it's fine.
Right.
But there's really no reimbursement for early stage NGS.
Right.
But I do think with the cost of sequencing coming down and eventually, this MRD does require sequencing to be designed, and I think there'll be broad applicability of MRD testing in the future. So you'll get both the whole exome sequencing, you get your results, and that enables your MRD tracking for those early stage patients. And then in the clinic, and you brought this, yes, it's actionable, but if I do, in my clinic, I use MRD. If somebody say stage 2, they have an actionable mutation and they end up testing positive on MRD, to my eyes, that patient has proof of stage 4 disease. And I've used off-label treatment in those that have a positive signal.
That's exactly right. I figured this was going to come up again, so I didn't ask it before, but if somebody's been on adjuvant osimertinib for 2.5 years and you're tracking them with MRD, and then all of a sudden you see, their EGFR mutation starts to rise in the circulation, that patient, in my mind, has stage 4 disease. So I think your treatment strategy has to change. You're no longer thinking about that treatment with curative intent, really. You'd be thinking about that patient as a stage 4 patient.
Thank you. Great discussion. Oh, one more?
Great, excellent question.
Patients right across the country. It's impossible to get enough
Excellent
patients
question.
or data.
Yes, excellent question. I was actually surprised the Alina trial accrued so quickly. Actually, with early stage ALK-positive lung cancer, that's actually very hard to find. A lot of those patients present in the metastatic setting. You make an excellent point. I feel like I'm a little bit lucky. I function in the Boston area. It's a large referral center for patients worldwide, honestly, to come for ALK-positive disease, ROS1-positive disease, a variety of these oncogene-driven lung cancers. So academic centers, I think, really are going to be the mainstay to test these small populations of patients in clinical trials. But you make an excellent point. These are small subsets of patients. And so is it going to be feasible for us to recapitulate the ADAURA trial or even the Alina trial in every single oncogenic driver? Absolutely not. People do not think that that's going to be that's not going to be feasible from a patient number perspective, and it's not going to be cost effective. But at what point do you feel comfortable extrapolating? So with RET-positive disease, can I say, oh, we have data from the ADAURA trial, and then maybe the data from Alina trial will be positive? Can I say the same thing is true for a RET-positive patient, even though I don't have the data? I don't know.
Thank you so much.
Thank you. Thank you so much.